Dallas was designed to be different, to test whole system change rather than technology. The program started by bringing usual and unusual suspects together in a sandpit. The sandpit encouraged the Dallas contributors to incubate multiple ideas, and from these many seeds, the 4 Dallas communities were selected. 2 were defined by geography, living it up in Scotland and more independent in Liverpool, while Year Zero and iFocus looked at issues that could unlock digitally enabled assisted living services everywhere.
The original idea behind iFocus was to pull together a collaboration of different types of organisation to address the problem of interoperability in its widest sense. And interoperability was seen at the conception of Dallas as being one of the main reasons, the main obstacles to widespread adoption of digital technologies within the healthcare system.
The assistive technology part of More Independent allows us to see that you can keep people out of hospital with the use of technology. It was a great kind of altruistic aim. Well, in this city, we've proven that you can do it by rolling out this kind of stuff at scale, based on clinical pathways, not based on boxes and gizmos, but based on where that clinical need is, where patients may benefit from it.
So that's apps, online products, but it's a program with a difference. It's not your usual NHS program in that it involves a wide range of partners from industry, partners from the voluntary sector, partners who provide services, but probably most importantly, it's a partnership with citizens in the city.
The original idea behind Year Zero was to put the citizen right in control of their own data. That enables them to manage their interaction with health and care services, whether it be hospitals or primary care or local authority and social care.
To actually demonstrate the concept of personal health records and actually how the individual can input into those records themselves, we developed a series of products that included a personal health record called A Better Plan and a secure social network called Good Neighbours. We developed the e-Red Book with a company called SiteKit, the digital version of the paper Red Book that's given to new parents on the birth of their child. In the later stages, we developed the e-Day Book, which was a management record for domiciliary care providers.
We had an idea, how do you recognise people as assets living in the community and pull those assets through in a way that helped them to support their own health and well-being? Living It Up today is an online service.
It's a website that's designed to help over 50s in Scotland to use technology to manage their health and well-being better. But it's got quite a broad reach in that we're also helping people to connect better in the community, have better digital skills, and so it's not just got a health focus.
We've got 4 main sections to the website. One of them is all about encouraging people to be able to give back and make use of their skills and the things that they know that they're good at. We've got a section on the website called Discover, allowing people to discover what's happening in their local area. And then we've got Connect, using technology to connect to other people. So we look at things like Skype, video conferencing, using social media. And then we've got a big section of the site that's really more health and care focused called Flourish. There's lots of digital tools and trackers to do things like track how active you are, how many steps you take.
For each of the 4 communities, the individual, be they citizen or patient, was placed at the heart of the new system, with redesigned health and care services around them. 6 high-level design principles, known as the 6 Cs, were adopted by Dallas to embody the changes the projects were trying to bring about.
Of the 6 Cs, Liverpool's kept at its heart connectedness, so being connected to our clinicians, being connected to our citizens, another couple of Cs, and that's led us into co-design, but also being able to collaborate, and not just collaborate with delivery partners, but being able to collaborate with citizens in terms of understanding their challenges, but also understanding their aspirations for health, their aspirations for technology.
The idea of connectedness was clearly central to interoperability, and this idea of connectedness of information, for sure, but also the broader idea of how you're creating a channel to connect people to professionals and to informal carers.
How does choice translate into what you're trying to do with Living It Up? And that was looking at things like, well, choice would be a menu of services. It wasn't just about, kind of esoteric theory. It was, you translate that into very specific things that you then had to go on and deliver. So community wasn't just the concept of community. It was very much about building an online digital community and seeing people as equal participants within that as well.
Converting those 6 C's of control, choice, community, connectedness, contribution and collaboration into practice meant each community surmounting the problems of deploying new services in a live and dynamic environment. This threw up new challenges for the projects and their users, both professional and public, but also for those tasked with evaluating the impacts of Dallas.
People say that Dallas is different, and I think that's very true, because it's completely different from the kind of randomized controlled trial, very controlled environment in which most academics are involved in evaluating. And I guess from our perspective, one of the biggest learning points in Dallas is about how do you learn how to deploy digital health technologies at scale. What are the real life challenges? Because so often we have randomized controlled trials, we look at what goes on in those trials, and they then, when the trial is finished, they may show some benefits, they may show not disbenefits, but even if they're beneficial, they often don't roll out and become real services. So Dallas was about real services being delivered to the public at scale. And that's never been done before anywhere internationally at the scale of Dallas in terms of the range of services being deployed and the numbers of people that were being approached.
The biggest challenge initially was cynicism on behalf of clinicians. I think that we'd been told by the government for many years that telehealth was the future, and the evidence was pretty poor, and we'd never yet seen a programme that had demonstrated real change to the patients that we see every day. And so the fact that we were able to organically grow that in Liverpool and win those hearts and minds was critically important.
One of the big challenges that kept coming up throughout the project was the area of information governance and data control and who owned the data. And in the case of the Red Book, it was a particularly pressing issue, I guess, because we had the product at quite an advanced stage of development. And whilst we were piloting it, the partner organisations were quite comfortable with that. But for any kind of wider deployment, they needed to know that they had the backing and approval of a wider authority, if you like, in terms of what could be allowed.
If we're looking at digital health, we shouldn't treat that the same as if we were trying to evaluate a drug, for example. And there's still a tendency traditionally, especially for health professionals, for example, to think that the randomised controlled trial is the only true way to evaluate efficacy or to evaluate whether something works or not. And I think that's a really bad model to stick to for this in particular, because there are a lot more flexible ways to look at evaluating something and whether it works or not. And especially in this area where you want to see what happens when you put it in the real world, you can't do a randomised controlled trial for that. And I think there's real value in looking at it much more widely than that.
The biggest challenges that we faced within Dallas, but the NHS faces moving forward, is that that real capacity, real innovation is going to come from engaging citizens in their care. Making sure that citizens, communities are engaged and taking control and doing more for themselves and their families. The challenge is that self-care, self-service is not within the DNA of the NHS. It's not within the DNA of practice. And that's translated through to citizen expectation of the NHS. Citizens expect services to do things to them, and that's how the system operates.
When you break it down, what you get to is the fundamental point that we want people to self-care, we want people to live independent lives, healthy lives. It's about them. So you've got to give them the ownership of their information and access to a variety of different means to give them choice about how they wish to do it.
So for the Dallas evaluation, we chose a very mixed methods approach. And so we wanted to examine from all the different products and services and activities that were going on throughout the whole Dallas programme. We wanted to examine which ones were working, which strategies worked best to engage with consumers and patients and citizens to actually get people to take up the products and services. And so that involved a qualitative evaluation and looking at the implementation process. And in particular, it involved looking at how to mainstream some of these products and services and how to make it best practice, the things that were working.
And one of the issues or biggest challenges in Dallas is the fact that it was never a fixed service or program or single intervention. It was a suite of different digital products and services that were being deployed that were continually changing. So one product or service might be brought forward and then it might not work out, it might be dropped and something else adopted and people would run with that. So that presents a real challenge in terms of thinking about what kind of measures you use, how you're going to look at cost effectiveness, how are you going to measure benefits.
To use digital technology successful in healthcare, you've got to take a step back and you've got to take a service innovation design approach. And by that I mean you've got to look at how you might do things differently. Healthcare is looking at continuous improvement in many cases, but there's a limitation to that improvement. At some point you've got to do things differently. You've got to find different capacities in the system. And in healthcare you've got a capacity that's almost unused, which is patients.
One technique all of the projects found beneficial when it came to identifying ways to do things differently was co-design.
With Living It Up, we really wanted to use co-design as the methodology that we would go out and make sure that we weren't just designing something that we thought people would want to use, that we were actually designing something that came from the community. I think that there are, certainly in the co-design process with Living It Up, there were a lot of people across Scotland living with all sorts of different conditions who were really engaged and really keen to manage their own health more. So I think there are lots of people who are ready for it. I think there's lots of professionals who are ready for it as well. But it's not everybody.
We had a wonderful co-design team who really helped shape how things were or really involved the public. And I feel personally that in all my years of working in public services, I've never truly embraced co-design. We had a wonderful team who comprised of Carers Scotland, the Alliance, who are an organisation who look after people with long-term conditions, and Glasgow School of Art. And I think that was probably the biggest revelation, to look at the whole design aspect.
In terms of Year Zero, we took different approaches to co-design throughout, which is also quite interesting. You can kind of compare and contrast. So if you take something like the e-Red Book, to me that's almost the perfect example of co-design. It was starting from a product that was known, so people were familiar with it, so there was an element of safety, but actually so much work was done by the various players around the Red Book that it really shaped and transformed how that product was going to develop over time. So we had the input of the health visitors and the parents along with the software development company, and that happened right throughout the entire development of the project, right from the beginning.
As a design team, we're used to the concept of co-design and co-create. As a design team, we're used to the idea of iteration and envisaging. Some of that was turned upside down when you start working in the healthcare sector, mainly because with a better plan, for example, we co-designed that with probably 300 or 400 different clinicians, and we continually got feedback as we iterated and developed the tool, but there was very little adoption at the end of it in comparison to the potential we all thought it had. And the reason for that was they didn't have a deployment plan. They didn't have a deployment plan because in order to deploy it, they actually had to redevelop the service. And they didn't redevelop the service because we didn't necessarily always have those stakeholders involved in the project who actually had the power and the control to redesign a service and deploy digital tools.
One of the key mistakes that we've learned from has been to assume there is only one route to deployment with one product, and to really scale you've got to be quite flexible in approach. So you've got to think about numerous routes to deploy technology. You've got to think about a number of products which are going to help people to self-care. And I think the other thing that can't be underestimated is there's got to be real appetite amongst not just the citizens but the practitioners who are engaged in those services along those pathways. They've got to have appetite, they've got to be excited, and they've got to have capacity and resources to change.
So, what would the Dallas projects themselves say are their greatest achievements and most significant impacts? The answers come in 3 areas: innovations that have shown how to do things differently, tangible and measurable impacts on healthcare outcomes, and benefits from industry healthcare partnerships that will create economic growth. I think within the Year Zero programme, probably the greatest innovation was something that actually you could describe as a building block rather than a complete service. I think by working through with our digital services, our personal health records, the information governance challenges of deploying those so that the health service can adopt it, by working with Dame Fiona Calder-Cartman and NHS England with the HSCIC to produce guidance that recognises that there is clinical data and there is personal health data, and by establishing the rules by which these can interact, we've done something that's widely applicable for other innovators to take forward.
One of the great successes that My supported was the House of Memories app. It was driven by our museum. It was designed by one of our local SMEs, where they had to truly understand what it meant for them to live with dementia and how that app could truly support what they did. And that really was fundamentally what was behind its success, because it was an app designed by those people for people living with dementia.
Key innovations for me, because I'm the community guy, have been around the innovations that have been people and community driven. So the mobilisation of our third sector partners to bring online 50 digital hubs, coordinated by the TUC and their learning branch, which have recruited over 300 volunteer digital champions, which have trained over 4,000 citizens and turned 4,000 citizens on to digital and being online. Great innovation.
Living It Up is a real live service. You know, it's out there, it's working. There are digital tools already on it, people are engaging with it. We've got 40,000 to 50,000 page views a month that's happening in Living It Up. We've got 19,000 people who've registered because they're interested in it and participating. So for me, innovation is no longer what we do. And we didn't actually engage with developing Living It Up because we wanted to innovate. What we were looking to do was to develop new services.
The history says that innovations take 17 years to be accepted by the NHS. And obviously we're trying very hard in the Digital Health and Care Alliance to reduce that time as much as we possibly can. There's no doubt that during the time that Dallas has been in operation, that people in the NHS have become much more aware of digital health. One of the issues, though, is the feeling now that all I need to do is to tender for and install some digital health, and the benefits will come flowing out of the ground. And actually what you need to do is to change the way you work.
But Dallas has been more than an innovation project. By responding to the challenges of deploying live services into the mainstream, the Dallas projects have seen significant impacts on health outcomes that could be repeated elsewhere.
We've worked with some champions of self-care who see the promotion of self-care and helping people to help themselves as being at the heart of certainly primary care. This is the future of primary care, and the future role for health professionals within primary care is to help people help themselves more effectively and help families to support people, other family members, more effectively.
Our lead clinicians stopped asking about the evidence base because they'd heard citizens say that technology and self-care makes their life easier.
We've got our GPs prescribing telecare. That's fundamentally different. And even we at the beginning of the programme never saw that coming. It wasn't actually in the original plan to go down that route.
I think the greatest claim we can have to having a measurable, direct impact on people's lives probably at this stage comes from the work we did in primary care with the creation of this multi-channel digital access to GP services in Birmingham. We put up a new model of accessing primary care via the web, via the telephone, via a mobile app, as your direct access to a doctor. And we've seen amongst that population a 20% decline in A&E attendance, and that's because they've got a primary care service now enabled by this technology that's responsive to them and gives them what they want. So they know they can rely on it, so they don't go to A&E.
So I think in terms of, healthcare benefits for living it up, what we're really looking at are behavioural changes in the individuals that are using the service. I think we're probably not looking at hard clinical outcomes necessarily in terms of, a reduction in somebody's high blood pressure or something like that. I think we're looking much more at, people are individuals and they see themselves as a person living with a diagnosis, but a range of other things. And what we've done with Living It Up is we've been able to design a service that treats people as a whole person. So the sorts of changes we're beginning to see are around people, sleeping better, being more active, being better connected to the people that love them, and feeling more, able to speak to their doctor about specific clinical elements of their health. So I don't think we've got sort of hard clinical outcomes necessarily. I think we're much more around a wider scale behaviour change where people are healthier because their lifestyles are healthier and they feel better because they're more connected and less isolated than they were before.
I was a fairly early adopter as the digital lead for the benefits of telehealth, but I think when the numbers came out, when we'd rolled it out to enough scale that we were able to look at some of the outcomes, and we started to quote a close to 20% reduction in hospital admission. Well, there isn't a drug that we prescribe that does that. There are very few interventions that the health service has ever been able to offer that can keep a fifth more people out of hospital. Instantly, that gets you thinking. Well, okay, we've done it for 2,000 people. What if we did it for 10,000 people? And that, for me, was the key switch in the city's culture.
For all the Dallas communities, collaboration between health and care organisations and industry, large and small, has also given some early indicators of how the transition to digitally enabled health services could generate economic growth, locally and nationally.
Because Liverpool now is starting to be seen as a place that knows how to introduce digital technologies to its business and its operating model, we have interest of not just SMEs who are thinking about setting up business in Liverpool, but also some bigger companies that are thinking differently about where their R&D base should be.
The last 3 or 4 years, we would say, have seen a dramatic progress towards a real market where people understand how to commission, specify, integrate, deploy, support digital technologies, which for us is great news. It means it's moved it from something which clearly had massive potential, the use of digital technologies in health and care, but it's moved it from the sort of early on the hype curve to where we think it is now, which is at the bottom of the ramp to real commercial exploitation, where it becomes a commonplace.
The contribution of SMEs has been absolutely at the heart of Year Zero, because taking the approach we did, which was the development of products, they were each led by the SME that was behind them, and each of them took the approach of it as a business proposition, basically, that we're going to develop a product that we ultimately want to have buyers for. So it wasn't just a concept. It wasn't looking at it as a proof of concept, let's see if this would work.
Health innovation is now written into the City Region Economic Growth Plan. There is European money's been focused into health innovation, and as somebody who's worked in the city for a long time now, it's been really difficult to get the economic regen guys turned on to health. Dallas has helped us to do that.
The 4 Dallas communities are confident that they've made real progress in terms of deploying services, capturing healthcare benefits, and building a market for digital health. But does that match the key messages emerging from the evaluation of the programme?
It's clear to us that there's a big issue in terms of readiness for digital health technology. If we're wanting to make it ubiquitous, then we need to think about it at macro, meso and micro levels. And when I'm talking about macro levels, I'm talking about what's the market readiness, what's the policy and legislation readiness. When I'm thinking about meso levels, it's thinking about what's the organizational readiness in health services, social care services, industry. What's the technical readiness there for in terms of our ability to roll out these kinds of services? And then at the micro level, thinking about patients, the public, consumers, caregivers, and also professionals. What are the barriers and facilitators? What are their readiness issues? There's a lot of rhetoric saying that the market is ready, we just need to roll out these products and services. And yes, in many respects, people are very enthusiastic. Companies and industry are enthusiastic about the products they're delivering and deploying. But when you get into healthcare, especially in the UK context, I think there's an issue about thinking about risk and benefits. I think on the legislation side, a big issue that's come up in Dallas again and again, across the programme, across communities, across services, is the issue of information governance and the legislation that we currently have. And we have information legislation for a reason. It's to protect citizens, to protect data, to provide reassurance that health and social care and personal data is secure. But when you start to move into consumer products and saying, well, the consumer is going to have their personal health record and they're going to gain more control, then that can come up against information governance legislation as it currently stands. And when you come to companies and social care and voluntary sector and NHS working together, then sharing of data also becomes a big issue. And it seems to me that our data has suggested that the information governance legislation is really not quite fit for purpose yet.
So after 3 years and engaging more than 150,000 users, what advice would the Dallas community offer to anyone wanting to embark on their own digital journey?
So I think to create a successful digital service in healthcare, there's a few different things that you need. I would say engagement from local healthcare providers is really important. One of the things we're trying to do with Living It Up is to get it embedded into pathways and local service delivery. So having that engagement and being able to explain to people quite clearly what your service is, what it does, and at what stage in people's journey they might want to be referred to it. That's really important. Having an accessible, engaging, entertaining platform. We know that there's a huge amount of choice out there on the internet and people aren't going to come and use your service just because they've been referred to it once. They're going to use it because they gain from it, but also because it engages them, and that's how people work on the internet. So making sure that you've got content that reflects your users and reflects their interests and their needs is really important. And then finally, having an infrastructure that's really solid and works really well. So content management systems that are easy for your content team to make use of, having sort of back end that's secure, that you're testing, as you should, relevancy, all of those kind of things I think add up together to create a really good digital service.
Get your clinical champions early, keep the models very, very clinical, and keep at it. There are naysayers out there abound who will tell you that it's a flash in the pan. We've proven that it's not. And so a dogged attitude to continue with what you believe to be right for the people that you're serving would be the best advice.
There are perhaps two different types of technology-enabled redesign of services. Now, one of them, typified by the eRed book, is where you're closely aligned to a clinical pathway. And here, what you need to really give benefit and to convince people of the benefits is you need a solution that needs to be worked through from end to end. It's very time consuming to iron those things out, the data flows, the various stakeholders, perhaps some national programs. But the great thing about it is once you have worked it out, there's no reason why that can't then work on a national scale. Now, on the other hand, what we found with the digital access to primary care work is something quite different. Because what we're really dealing with is the very front of people's experience and interaction with the health service. We're dealing with access to a GP. Here, the adoption can be remarkably quick, and the benefits can be shown remarkably quickly. So there, 60,000 patients, within probably a month, as we started rolling this out through GP practices, we had 3/4 of people using the service. Now, the difficulty there is it's really quick adoption, it's really quick benefits, but probably rolling that out organisation by organisation, everyone's going to be very slightly different.
From an evaluation point of view, for me and what I would tell other people embarking on this type of programme, anything to do with health and wellness, I would think not purely about evidence-based outcomes. I would think about it much more widely than that, about how you can get your service into the hands of people that might benefit from it. And I would think about an evaluation where you can look at the bigger picture and look at how it actually works in the wild or in the field rather than just in controlled lab settings. I think that's really important for this digital health sector.
I think Liverpool has completely signed up. Our governing body has agreed £15 million over 2 or 3 years to support this. It's the second biggest investment in Healthy Liverpool will be for this digital programme. So from that point of view, Liverpool as a city is convinced. I think that our patients are starting to see the benefit. I think in terms of the whole country, in terms of the message centrally, my best advice and what I would love to dearly see happen is for them to just allow local organisations to do what's right for local populations. Give them the freedom to innovate differently, because the solutions for Chichester aren't going to match the solutions for Liverpool.
Any local innovator who wants to change their ecosystem can get lots from DACA, and it can be in two forms. Firstly, it can be in documented learning from Dallas, which is available already on the DACA website, and that's everything up to and including the medical apps processes. In addition to which, we can put them in touch with the people on the Dallas programme that actually did the work, so they can get some consultancy directly from people who developed it in Dallas.
Find the clinical champions and work with them. Find the expert patient groups, the people who will actually bring the service user's point of view to the table. Work with them. Find the local innovators, the SMEs such as ourselves and other organisations who've worked in a similar way within Dallas. Work with them and together work out a programme of change that's led by the ambition for the service, that's led by the best clinical guidance, that's led by what service users actually want, and that's facilitated by creative, innovative, fast-moving SMEs. That's a recipe for successful transformation that we've found within Dallas.